evening to everybody. Thank you for joining this next session where we will be giving technical guidance from USAID. My name is Catherine Hoflick, and I'm the Senior Capacity Advisor with the Office of HIV/AIDS here in Washington, D.C. I'm excited to be moderating this session where we will be hearing from our technical experts from USAID for PrEP, Biomedical Prevention Products, VMMC, and social and behavior change. Please note, I'm supposed to also tell you that the COP22 guidance for all of the COP22 guidance should be coming out approximately on the 8th or thereabouts publicly. So that'll be next week. We'll have the publicly available COP22 guidance. Now in this session, each speaker is going to share their technical guidance for approximately 10 minutes. And throughout the session, you can use the chat function to be typing in your questions in the chat for each of them. Just please be specific. If you have a question on VMMC, please be specific about which person that you're asking the question of or which topic. And then we'll, at the end, we can read out the questions and you can come off mute and you can ask your questions live of the technical experts. So in just a moment, it'll be a few moments. We have our translators will join in a few minutes. And so then you will be able to have interpretation shortly, but not quite yet. Our interpreters are only joining from the previous sessions. And so they're taking a little bit of water and then they'll join us in just a moment. So when you do see that there should be a little globe at the bottom, a little globe icon pop up on your Zoom window so that you then can click whether you would like to listen in French or Portuguese. So first, I'm going to welcome Alison Kimmel, who's the Biomedical Prevention Advisor. And then Shannon Allen will come on. She's a health science specialist on new biomedical prevention products. Then Valerian Kigundu, our Senior Prevention Advisor, will speak to us about VMMC. And then finally, Jacqueline Devine, our Senior Social Behavior Change Advisor, will speak to us about social and behavior change. So first, I'd like to welcome Alison to go ahead and come on. And then again, everybody feel free to introduce yourself in the chat window and then start up with your questions in the chat. Welcome, Alison.
Okay, great. Thank you, Catherine. And greetings all and welcome. As Catherine said, my name is Alison. I'm a Biomedical Prevention Advisor here at OHA, working mostly on PrEP. Next slide. So I'm going to kick off and start with an update on pre-exposure prophylaxis and new products. And first, we're going to talk about where USAID's PrEP program is, provide some updates on the evidence and guidance, and then talk about PrEP going forward. But starting with this slide, this is just to give some context and highlight the progress that USAID's PrEP program has made. So starting with the visual on the top right, USAID has initiated this year nearly 378,000 individuals onto PrEP as of just Q3. And this is compared to 162,000 in all of the previous fiscal year. So we see this as a very huge jump from the previous year. And our KP PrEP program has grown exponentially, 400% since fiscal year 19. And in the current fiscal year, we are on pace to double from the previous year. Next slide. And as of FY21 Q3, 13 countries have already reached or surpassed their PrEP new targets. That is the target for new initiations on PrEP. There have been many successes, but just to highlight a few, USAID Haiti has been able to successfully activate more PrEP sites despite numerous challenges and are at 158% of PrEP new achievements. South Africa really accelerated their PrEP program from 14% achievement in Q1 to 72 in Q3. Nigeria, which is a newer program, has had strong achievement in PrEP, scale up among the general population. And Zambia and Zimbabwe have seen continued achievement despite significant COVID outbreaks. They've expanded PrEP to pregnant and breastfeeding women, and are really leading the way on new product rollout, namely the PrEP ring. Next slide. And more of USAID PrEP program success can be attributed to local partners. Local partners have made up an increasing proportion of PrEP results quarter over quarter. This visual shows data from FY20 Q3 through FY21 Q3, with local partner share results in red. And globally, local partner PrEP new target share has increased from 49% in FY20 to 65% in FY22, the current COP year. So really highlighting efforts to transition PrEP to local partners. Next slide. So in this past COP year, COP20, USAID PrEP programs have had notable successes, as well as, of course, significant challenges. These successes include making up 60% of all of PEPFAR PrEP new results, high achievement among KP, already at 93% achievement of PrEP new by Q3. Partners have really continued to successfully adapt PrEP programs through decentralized and differentiated service delivery despite COVID-19. PrEP ring implementation studies and other preparatory work has started. And we are on track to achieve our really ambitious COP20 target of 536,000 new PrEP initiations. This year, of course, was not without challenges, which included ongoing policy issues, so policies that limited PrEP use due to stringent clinical monitoring, population or age criteria, and criteria which limited who could deliver PrEP, gaps in the operationalizing policies. So once policies were updated, there were challenges around implementing with fidelity, minimal demand creation efforts at a national level in some countries, over medicalization of PrEP, which adds costs and barriers for clients, and then low achievement of age-UIW targets. So still not reaching this priority group to the extent that we intended. Next slide. But we are seeing more and more data coming out of various settings, both in higher income countries and lower and middle income countries, that show that where PrEP is scaled up, PrEP has high impact. Notably, results from these studies shown here show that individuals take PrEP when they see themselves at risk and not at other times, that people adjust their PrEP use according to their seasons of risk, and that even with imperfect use, PrEP can have a significant population level impact. So where PrEP is introduced on a large scale, there's a big impact on new infections. So this reinforces that we need to get as much PrEP out there as possible. It has an impact. Next slide. There have recently been some key updates to WHO and PEPFAR guidance related to PrEP. In July 2021, WHO released updated recommendations on creatinine screening for PrEP. They recommend it now be optional for individuals younger than 30 without kidney-related comorbidities. For those older than 30 or younger than 30 with morbidities, they can be screened once within 1 to 3 months after oral PrEP initiation. And more frequent screening than once is only suggested of those of any age with a history of comorbidities, those 50 or older, or those who've had a previous creatinine clearance result of less than 90 ml per minute. WHO recently announced that updated recommendations will be in the next there will be a number of updated recommendations coming out in the next several months related to hepatitis B and C screening for PrEP users. Also event-driven PrEP, which will likely be amended to include all cisgender men. Time to protection to further streamline how people use PrEP, and also some recommendations on PrEP service delivery in the community, PrEP monitoring and evaluation, and other components, with a focus on finding a balance between providing essential services with PrEP and streamlining PrEP service delivery to improve access. Next slide. WHO's guidance also now supports the use of HIV self-testing during COVID as an interim measure, and is currently reviewing evidence on the use of self-testing for PrEP initiation and continuation. PEPFAR supports this update and it is included in PEPFAR's programming during COVID-19 guidance. And then As Catherine noted, COP22 guidance is coming out this month for public comment, and we really encourage everyone to take a look and send feedback. And the PEPFAR programming during COVID-19 guidance includes some other recommendations related to PrEP services in specific populations, such as dreams and other programming aspects. Next slide. You may be aware of updates to PrEP MR and custom indicators. With the MR 2.6 updates, the definition of PrEP new has been expanded to include non-oral PrEP regimens. There is also a new indicator, PrEP CT or PrEP continue, which is replacing PrEP cur. PrEP CT is defined as the number of individuals, excluding those newly enrolled, who return for a follow-up visit or reinitiation visit to receive PrEP during the reporting period. It has disags for age, sex, HIV test result, KP type, and pregnant or breastfeeding. It differs from PrEP cur in that, just like the updated PrEP new definition, it includes non-oral PrEP regimens. It does not include PrEP new, and PrEP CT is not cumulative. So in COP21, partners will report on PrEP new and PrEP CT, do not report on PrEP cur. The OHA custom PrEP indicators have also been updated. All custom indicators now have a pregnant or breastfeeding disag, and PrEP CT verify is replacing PrEP cur verify to align with the new MR PrEP CT indicator. And then the month by age sex disag for PrEP 1 month has been removed and replaced with the simple age, sex, KP, and pregnant breastfeeding disag to align with the other indicators. And the updated MR guidance and OHA custom indicator guidance are linked on this slide. So next slide. And this is my last slide. So where will we be going in COP21, this current COP year, and COP22? Well, we want to work towards normalizing PrEP. So wide awareness and acceptability of PrEP while also ensuring clients at risk have access to PrEP, and expanding policies to support PrEP access beyond key and priority populations. So anyone who wants PrEP can access it, and PrEP isn't viewed as only something for key populations. Again, evidence shows us that where PrEP is introduced on a large scale, there's a big impact on new infections. And also working towards normalizing how clients use PrEP. We know PrEP is not used like treatment. PrEP clients use PrEP according to their need and risk, so PrEP use is inherently flexible. We will continue targeting gaps in implementation, so using data to identify, for example, where there are high testing but low PrEP new numbers, overcoming minimal reach to AGYW, and expanding PrEP for pregnant and breastfeeding women, and tracking this with our custom indicators. Expanding event-driven PrEP for all cisgender men. Really thinking of how to overcome the over-medicalization of PrEP, streamlining service delivery and lab tests as needed. Expanding and improving access through differentiated service delivery and community services, and then exploring private sector access points and support. And as new biomedical prevention products come to market, start thinking about what would the ideal product mix look like in your country? How will these products build off of the oral PrEP implementation platform? Here I'll mention 2 products that will be more imminently available for implementation. So as mentioned, PrEP ring implementation studies are or will be underway in some countries in COP21 and COP22. Other countries have started working on policy guidance, SOPs, and developing an enabling environment for ring introduction. And then injectable long-lasting cabotegravir or injectable PrEP is still a way off, with a number of implementation questions, including cost, how and who can deliver it, will have to be by a clinician. More needs to be known about the potential for resistance or interactions. So these are implementation questions we can work on now. So I'll leave you all with that. Looking forward to our work in COP21 and COP22. It's a very exciting time in the PrEP and prevention world with, as noted, more and more evidence coming out to show just how impactful PrEP is. And as we work to meet clients where they are and improve awareness, acceptability, and uptake of PrEP, local partners play a bigger and bigger role in PrEP implementation. So thank you, and I will turn it over to Shannon.
Thank you, everyone. I really would like to thank the organizers for allowing me to represent the USAID's Research Division's contributions to local partner engagement in new product introduction. We really appreciate the opportunity to give you a glimpse into our interactions and engagement with local partners, which is pushing the research agenda forward for new products coming down the pike. Next slide. For this slide, I wanted to do a bit of stage setting so that everyone on the call is aware of the current flagship research projects that are currently being implemented within the research division, which really illustrates our how the research that we support is anchored to PEPFAR programs in the field. So on the first quadrant on the left-hand side at the top, it really talks about our work in vaccine research and development and has a huge component of research capacity strengthening. Here, we're supporting research to develop a safe and effective HIV vaccine that are vaccines that are available and accessible for populations at risk of HIV acquisition. A core component of this research is that it is led by African and Indian research institutions. And the second quadrant on the upper right-hand side is the Microbicide R&D Collaborative. As some of you may be aware, the USAID Research Division has a long-standing history of supporting biomedical HIV prevention research of innovative technologies that meet the complex needs of the most vulnerable populations, with a specific focus on women, especially AGYW. And this particular project is still under procurement, so I can't give too many details, but here we aim to continue supporting research that builds on our history to develop a suite of HIV prevention options and technologies that are acceptable, safe, affordable, cost-efficient, and deliverable for women, especially young women in sub-Saharan Africa who are at risk. In the third quadrant on the lower left-hand side, you'll see our ongoing research project called CASPR that has a strong focus on HIV research policy and advocacy communication. CASPR is primarily focused in key African countries that are invested in ensuring that next-gen HIV prevention trials are using stakeholder perspectives, developing policy for supportive financing, accelerating progress towards an integrated and woman-centered research agenda, and reducing gaps between R&D and service delivery. Lastly, on the lower right-hand side, we have our newest and very exciting Microbicide Introduction and Access Consortium, or MOSAIC, whose vision is that women will have access to multiple effective biomedical HIV prevention options that meet their needs through targeting, optimizing, and expediting introduction of and access to highly impactful products. Next slide. Next slide. So this next slide really illustrates, go back, yes, thank you. This next slide really illustrates the breadth and the depth of our local partner engagement through the aforementioned cornerstone research projects that I just talked about. Through the 4 projects, we have continued to strengthen capacity, and we have observed that this capacity strengthening of local investigators, researchers, and scientists has transitioned to extraordinary leadership and ownership of research. We will continue to these efforts to promote leadership through capacity development so that the potential is realized and a sense of ownership is gained. A few of the types of local partner leadership engagement that we support include having local partners that are equal strategic partners for scaling up oral prep and preparing, promoting local partner leadership as a priority in developing approaches to expediting women's access to biomedical prevention products through our introduction and access portfolio, bolstering efforts to promote African investigators as principal investigators, and increasing scientific capacity at many different levels through R&D research and clinical trial design, partnering with local partners and researchers to leverage existing capacities and expand those capacities to preclinical R&D of new products, as well as phase 1 and phase 2 clinical trial design and implementation, and leveraging African-based partners to lead activities in developing advocacy networks, translation of research, inclusion of rights and interests, and from trial participants, and improving policies for new products. Next slide. So what's happening in COP22 that is relevant to our local partners attending this event? Well, at this current time, something really extraordinary has happened. We now have additional options beyond oral PrEP and condoms for HIV prevention. I'm sure you all are aware of the PrEP ring by now. It received WHO recommendation in January of 2021, and the guidelines were completed in July. We now have national registrations in African countries that are ongoing, and some countries are ready for rollout of the ring with implementation science studies and have implementation science studies planned where there is registration. As far as for other countries with PrEP programs, we are hoping to continue to work with you to think about new product rollout. Everyone is also aware of the CAB containing PrEP injectable that has achieved extremely high efficacy results in recent clinical trials for men and for women. This product will soon undergo the FDA regulatory approval process. However, prior to rolling out a product like this, there are some additional factors that we just don't have the answers to yet. These include testing methods before administration of the PrEP injectable. Although the efficacy results in the clinical trials were truly exciting, there are a few instances where patients were given the injection, likely when they had already acquired HIV. And so because the traditional testing methods that were used to detect infection were not sensitive enough, those infections went unnoticed for some time while the patient continued to receive their course of injections. There are also questions around missed appointments and how long patients are truly protected should they miss their appointment. Another concern and a famous question that Allison brought up earlier is centering on the tail and the potential for resistance if a patient chooses to stop the injectable for whatever reason, but could become infected with suboptimal drug levels. Another consideration is around the timing of injection, which is every 2 months, with other commonly used medications such as Depo-Provera contraceptive, which is given every 3 months, and how to balance those. So these are some of the important considerations to understand as the drug nears regulatory approval. So we need your help to continue to identify these gaps and determining rollout feasibility for this type of product. And so as part of our ongoing work in COP22, we intend to address some other challenges and considerations that would be important for local partners to consider, such as supply chain planning, demand generation, informing policy, and better understanding potential users. Next slide. So what can we learn from investing in research to inform the rollout of new products in the real world? Well, in the real world, we need to address considerations around scale up and delivery. If you think about manufacturing, different products have different manufacturing processes, and therefore different capacities would need to be built to manufacture those products. Also thinking about service delivery, who is actually responsible for administering the product at the service delivery level? Where do users prefer to receive these products? How should people be administering these products, and how should they be trained? Thinking about the end user experience, we need to explore what counseling and messaging looks like for missed appointments and how this counseling will be different based upon the product type, whether it's oral PrEP versus PrEP ring versus PrEP injectable. And we need to ensure that these products are not pitted against each other, that one product is not better than the other, but that PrEP injectable and PrEP ring should provide additional options along with condoms and oral PrEP for people to choose from, so the language here matters. Other research questions at the more technical level include understanding the potential for drug-drug interactions, as Allison mentioned earlier. We know that the PrEP ring and the PrEP injectable are safe to use with commonly used medications such as hormone-based contraceptives, but what about those who are taking drugs for malaria or TB? And what does this product look like in populations not generally included in clinical trials, such as AGYW and pregnant and breastfeeding women? For the PrEP injectable, ViiV, the creator of the injectable, They're actually getting ready to conduct 2 studies in adolescent populations, HPTN 083-01 and 084-01, to better understand safety and acceptability. And also, as part of these follow-on OLE studies, women will likely not be required to use a long-acting reversible contraceptive. So we'll be able to know how it works in those populations. For the PrEP ring, there are 2 ongoing studies, Deliver and Be Protected, to study safety and PK in pregnant and breastfeeding women. And additionally, the REACH study is investigating safety and adherence in AGYW. So these are just a few of the important things that we would like to have you to continue to think about, our local partners to continue to engage us on. Next slide. And so I'll turn it over to the next speaker who will discuss VMMC.
Thanks very much, Sharon Allen. Good morning, ladies and gentlemen. My name is Valerian Kigunda. I'm the Senior Advisor Biomedical Prevention, supporting medical circumcision services based here at OHA. I'm greatly honored to speak to you about VMMC and how our local partners have started contributing to services in medical circumcision. On this first slide, we show our contribution to medical circumcision since 2007 until the end of Q3. We've so far circumcised close to 27.4 million. And the graph shows contributions from the different countries. Next slide. So this slide shows the VMMC performance trends and targets from 2016 to 2021. As you can see, both targets and results were increasing until 2019, but we saw a dip in 2020. But looks like our performance will come up again in 2021, though the targets were slightly lower. Next slide. This slide shows VMMC achievements by agency during FY21 from Q1 to Q3. USAID contributed 65% of that target, and of course USAID overall contributes about 30% to the overall target. Next slide. On this slide, we show the achievement of annual targets just during Q3. As you can see, our Q3 was around 70% for all the quarters, including Q3 of 2021, but in Q3 of 2020, there was a dip of close to 50% because of COVID-19. Next slide. Here we show age shift to older men and adolescents being sustained since FY21 Q1. As you can see, starting this year, we barely had any circumcisions under 15, which means that many countries made efforts to achieve the proposed age pivot guidance. Next slide. Then on this slide, which shows USAID's performance, earlier I mentioned that we had achieved close to 65% of our target by end of Q3, but on the extreme left, we can see contributions from the different countries. There are some countries that have continued to excel despite challenges that we shall talk about briefly. Zambia, Uganda doing quite a great job, and a couple of other countries had a few challenges. But overall, COVID-19 continues to have an impact on the VMMC program with varying levels of target achievement. And then on the right, we show how countries were able to pivot out of the 10 to 14. At least all countries were able to circumcise 100% clients who are 15 years and older, apart from those who are using shingling in 13 and 14-year-olds. Next slide. This slide shows the VMMC local partners making contributions to the VMMC program. There is variation in performance observed across countries. As you can see here, some of our local partners, for example, in Uganda, on the extreme left, that column on the extreme left shows how some of our local partners in Uganda have done a tremendous job. Whereas some of our other partners have had a couple of challenges, but we hope if we get our results at the end of Q4, we are likely to realize some jumps since many countries were able to open up in Q4. Next slide. This slide kind of highlights some of our overarching operational priorities, which are mainly 5 regarding targets, quality and safety, demand generation, supply chain, and sustainability. These have been the same, so I won't go into the details. Next slide. And on this slide, those specific priorities are explained in detail. One specific one included here is the mitigation to mitigate the impact of COVID-19, which has been one of our challenges during the last 2 years, if I should say, since March 2020. Our objective was to accelerate safe reopening and implementation of VMMC services during COVID-19 by adapting successful demand generation approaches and monitoring compliance and performance. The others are the same as you've seen in the previous slide, and I want to go through the details. Next slide. So I spent a few minutes to talk about COP22 guidance, just to explain what is new. I start off with the age pivot. We continue targeting clients 15 plus, and there is a question here whether we should actually continue monitoring the age pivot. This is food for thought, but my thoughts here is that I think we really need to continue monitoring the age pivot, given that some countries had really low volumes and they may struggle once they open up fully. When it comes to COVID-19, we would like to continue safe and cautious implementation of VMMC services in the context of COVID-19 and observe and implement COVID safety guidelines, but also scale up new or proven adaptations to allow continuity of services in facilities or vehicles where COVID-19 guidelines can be observed. On the right, we want to continue promoting effective and safe VMMC methods. Shingling is getting popular, so we would like to ensure that clients who are 13 and 14 can receive that method, but of course with prefer approval. There are a few countries that did start using shingling in those age groups, but then shingling is available to all age groups without any need for approvals. Use of dorsal sleeve or sleeve resection for surgical methods. We continue to advise countries to avoid forceps guided, because we had a couple of challenges with that. Adequate and high quality supply chain, advised to buy through PSM mechanisms. There are many advantages when we have economies of scale, because we can bargain for lower prices, but we can also ensure quality of products. And then to adhere to WHO approved and prefer recommended surgical kits or devices. Next slide. Again, on this slide, we talk about 2 main changes that are coming into COP22 guidance, as you will see once it's available on November 8th. The first one is VMMC eligibility for HIV positive men diagnosed at VMMC facilities, all already HIV positive, with or without ART. So for HIV positive men seeking VMMC services, the goal is ART. We need to ensure that these men, once they test positive, they start antiretroviral therapy as soon as possible as priority, instead of taking them through circumcision. VMMC needs to be deferred until these men have had ART for at least 3 months, or if a viral load is available, we should look at a viral load that is less than 200 copies per mil. But this is not necessarily a requirement. As long as they have been on ART for 3 months, then they can be circumcised. Clients should be linked to ART care and treatment without stigmatizing them, and appropriate messaging needs to be developed in that regard. Decisions need to be made for men who will opt out, as HIV testing is optional, as most of you know. So messages need to be emphasized, especially for such groups that will opt out of testing, because we shall not be so clear about their status. Then the second change is on telephonic follow-up, which is being codenamed TFU. Language has been updated to promote telephonic follow-up and not called virtual, as this may include other electronics, including computers. We need to evaluate eligibility for this because some clients may not have phones. We also it must be completed. Once we do telephonic follow-up, we need to complete notes. After that conversation, we need to complete notes in the client's CRFs. Clients are not eligible. Clients who are not eligible must be followed up normally, including clients that may have severe adverse events. Next slide. So on this slide, we show some of the local partners that have contributed to VMMC services in a little bit of detail. On the top, we have some of the local partners that have been already established in the countries. And then on the lower level, in red, we show some of the transition partners or partners still working as sub-partners, but contributing enormously. So back on the top, we have local partners in Tanzania. We have AMFTA, who have been in Tanzania for close to 2 years now, and it's the only local partner in that country supporting in USAID supporting VMMC services. Then in Kenya, we have a couple of local partners, including AMREF. There are about 3 local partners there. AMREF, we have GOO, University of S&T, and then we have a local partner based at the University of Nairobi. And then in Eswatini, we have the Look Commission, who has been around supporting beyond VMMC. It's a community-based program, a community-based partner that supports other programs, but recently has shifted to support more of COVID-related services. Then in Mozambique, we have CHOVA, a community programs partner who is supporting demand generation and communication. Malawi has 2 local partners supported through PSI and JAPAIGO. These partners are transition partners, but both of these partners are contributing to direct service delivery, and they provided results to the COP21 targets. Next slide. So in conclusion and lessons learned, VMMC remains cost effective, but must be targeted to older men or adolescents ages 15 plus to maximize prevention benefits. Local partners and transition partners made significant contributions, as we've seen, to overall results through different ways, including demand generation, direct service delivery in countries where these partners are now present. Although local partner performance was a bit lower than global IP performance, we recognize the milestones to transition the VMMC programs from global to local partners, which we think will contribute to sustainability. Local partners have demonstrated their ability to safely implement VMMC programs. Suboptimal performance during COP20 is contributed to COVID-19 interruptions, transition and funding delays, and delays in approvals from the Ministry of Health, among other challenges. And lastly, working with local partners across countries, we hope is going to strengthen our sustainability plans. Next slide. I think that's my last slide. So thank you very much. I hand over to Jacqueline Devine.
Thank you for that. Jacqueline Devine, as Valerian introduced me, thanks to you for that. I will be talking to you about how we can leverage social and behavior change to support our treatment as well as prevention outcomes. Next slide. So as I kind of already alluded to, I really want to highlight how SBC can support clients and our outcomes of interest throughout the continuum. And I will share some examples and some resources that you can consult after this session. Next slide. So a little background, SBC, social and behavior change, does not have an explicit mention or a separate dedicated section in COP guidance. So the guidance that I'll be sharing today is really drawn from best practice in the field and some of the recommendations that we as social and behavior change advisors have based on the technical assistance we provide. SBC is really traditionally associated with prevention and demand generation, but we really want to point out that the same tools and approaches and principles can be used to really support the entire continuum, and that's really what I want to emphasize today. You'll find on the bottom of the slide how the Global Health Bureau at USAID defines social and behavior change. Oftentimes you'll hear proxy terms like IEC, SBCC, health promotion, health communication, but SBC is a little broader than that, and we can talk about that later. Next slide. So just to point out that our administrator Power is a big proponent in behavioral science, in sciences, and has spoken out at numerous events, including this one at the UN Behavioral Science Week in June, on really importance of understanding behavior as really a foundational component of our work. And so stay tuned to this space. I'm sure we'll hear a lot more from Administrator Power, but it's really to note the importance that is increasingly placed within the agency. Next slide. So I mentioned COP guidance. Here is how we kind of see elements of SBC kind of peppered and sprinkled throughout the document. For example, COP guidance mentions human-centered design, mentions stigma reduction, U equals U, and also the use of private sector approaches, marketing, for example. So just to recognize that SBC is in the COP guidance, but there are often different kind of terms used to refer to them. Next slide. This is a really interesting and useful framework developed by Johns Hopkins University Center for Communication Programs on where SBC really figures into what they call the circle of care. So how SBC can support clients to access service before service provision, so through demand generation, which was mentioned by all three of our previous speakers, creating an enabling environment, setting supportive norms, and then SBC can also support that client-provider interaction. So during service delivery and post-service delivery, SBC can boost adherence, maintenance, behavioral maintenance, and connect to community support. So I really will be kind of talking us through examples of SBC throughout this circle of care. Next slide. So here's an example of how demand creation has been used to increase testing, particularly among men. And this is an example of a proof of concept done by RISE in Nigeria called Valor. And they used, RISE used human-centered design to really get at the emotional aspects of why men are hesitant to get tested or not. And finding that support and that kind of community support and feeling part of something bigger is really important. And so a small ad agency was used to translate these insights from the men into different public service announcements, which were then kind of posted in Facebook and different social media. And then a VIP guide, which was a rebranded virtual navigator, connected with men and kind of addressed and had a conversation and hopefully led them to get tested and supported them in the linkage to treatment. Next slide. This is a more old school but effective SBCC intervention that took place in Mozambique. Sawa sawa means same, and it was really meant to reduce stigma, creating an enabling environment for accessing services. And this used community radio to community dialogue and brought testing to the community. And research showed that exposure to one or more of the activities in Sawa Sawa was associated with an increased testing uptake among men. Next slide. So we talked, all three speakers talked about the importance of demand creation for biomedical services, and there are so many resources available in PrepWatch and other areas, other sites. Discover Health, for example, really leveraged in Zambia the power of human-centered design to really develop effective tools, digital solutions, and really kind of got at the audience insights to really, know how to frame and motivate uptake. Next slide, next slide. The same kind of human-centered design approach to really get at insights, to understand pain points and drivers and motivators and barriers for potential clients was used for heavily in VMMC. This particular example from Malawi, HCD was used to get insights that informed job aids to really facilitate that conversation between providers and clients to address some of the misconception and lingering myths around VMMC, and how community mobilizers were shaped and chosen, and the strategy for that was also informed and part and parcel of this package, which really contributed to an overachievement of targets. Next slide. We talked about how SBC can be used to facilitate that conversation between providers and clients. Here's another example of a job aid that was done to address provider confidentiality, which was based on our research in Zambia and elsewhere, of course, a barrier to service uptake for men as well as adolescents. This job aid is called NZI, and it means shh. And it's really to nudge providers, giving them concrete actions on how to address confidentiality. And there's also a pledge, so reflecting a lot of the behavioral science findings around the need and the role of commitment devices to go from intention to actual behaviors. So nice example here from Zambia. Next slide. Here's an example not from PEPFAR. So it's good sometimes to look for examples outside of our box, outside of our world. And this was a small low-cost study done in Tanzania and Shinyanga region by University of California in Berkeley. And it really looked at pain points of the treatment journey from diagnosis to continued adherence, and developed with HCD through HCD 5 profiles. And then they used behavioral economics to develop what we call nudges. You might have read the book Nudge, heard about it. And the three nudges were a social proof, a prime, and a cue. I won't go through all that, but you'll see on the upper right, this client who goes to a clinic, and every time a client goes, they put a leaf on the baobab tree, and the baobab was really meant to symbolize this community support. But what happened as clients attended their sessions, they saw this tree grow, and that provided a social proof that yes, people do remain in care. And interestingly enough, 6 months after the intervention had ended, continuity in treatment, so our old school retention, increased by 8 percentage points, not negligible for a very low cost study. Next slide. Here's something to really keep an eye on, and this is, I'm sorry, there's a typo here. We were not able to fix this. It's in Malawian Zimbabwe, so you have to remember that. And it's led by SGAC, and really with a private sector kind of approach around really reframing ARVs and living with HIV to really kind of create a more positive enabling environment. And these are screenshots from a virtual booth that PSI had at IAS. And it shows you some of the key insights from the human-centered design kind of data collection. I think the second bullet on the top right about how really taking a pill every day reminds you, and it means I have HIV, and that kind of association needs to be broken, because that is really contributing to lower adherence for a segment of the population. So Flip the Script is a new initiative to really reframe what it is to be on ARVs. Watch this space, it should be very exciting. Next slide. Something I think most of us hopefully are already aware of is a very exciting approach in South Africa. It's more than SBC, it's a more integrated, comprehensive approach about really rebranding services for men, addressing some of the pain points, the barriers, the emotional drivers as well that men experience. So MENA is really about me, something that is for me. The service delivery is reshaped by that. There are Coach Mpilo is really about reimagining peer navigation. And then an interesting tool that's available is called BOK bottles. And it's a job aid to really explain how treatment and visually explain what viral load is and how you can go to viral load suppression, and ultimately what does U equal U really mean for clients in terms they can understand and can relate to. Next slide. So really what I hope you've taken away today is you saw all this use of HCD and different types of insight gathering, what your clients know, what they believe, and what they feel. It's also about emotions, right? Collecting insights around barriers and drivers is really the foundation of a client-centered approach, and that is something that Administrator Power has really stressed in her speeches so far. I hope we've shown that SBC can really be applied at all points along the HIV continuum, and that if it's done well, well-resourced, well-executed, it can produce measurable results for improved HIV outcomes and sustained epidemic control. Next slide. On the docket, we hope you can take a little break after the session and join us immediately. There's another typo here, sorry about that. 9:45, we have an SBC session at the local partners meeting. We will be having panels from Haiti, T-Mark from Tanzania, and Nueti from Mozambique, all local partners telling us about their SBC programs. We hope to be able to have key principles of HIV SBC at an ASAP webinar, date to be determined, and hyperlinks here for some resources around demand creation, for example, on PrepWatch, MenStar, Breakthrough Action and Research, SBC flagship project for USAID, and Engage ACD. So that's it from me, and we look forward to your questions. Thank you.
Great. Thank you so much, Allison, Shannon, Valerian, Jacqueline, for those great presentations and getting us up to speed on the COP guidance. So we have a couple of questions that have come through the chat while we've been in session. And I'd like to give an opportunity to Daniel, Daniel Kazozi, who has asked two questions, actually, one for Shannon, and one for Valerian. Daniel, would you like to come on camera, maybe, and at least on voice, open your microphone? You had a question about the PrEP ring efficacy, as well as one about TFU eligibility. So would you like to come on camera and ask your questions? Otherwise, I'm very happy to read them out loud. All right, well, I'll just go ahead and read them and hopefully then we can get some additional messages in the chat, additional questions, and also you can feel free to raise your hand and we're happy to take questions as well. So the first one is for you, Shannon. Daniel says, there's concern about the low efficacy of the PrEP ring, about 50%. What's your view on this? Is it possible to develop a ring with 2 ARVs to improve efficacy? Would you recommend non-inferior studies comparing oral PrEP and the PrEP ring? Shannon, would you be able to come on and give us an answer for Daniel's very good question?
Sure, absolutely. I did also provide some answers in the chat just for documentation in case we might have lost Daniel. But thank you, Daniel, for your question, if you're still on. I think for that first question about efficacy, we have to keep in mind that the most effective prevention option for a person is one that they can use correctly and consistently. And so male and female condoms or oral PrEP are great options for some, but not everyone can or wants to use those options. And so those women in particular need additional options. And for some, the ring will be the best or only suitable option that works for them. So yes, efficacy is very important as part of the equation for prevention of HIV, but acceptability and adherence are also very important and just as critical. And studies have shown that high acceptability of the ring leads to high adherence for many of the participants of some of the later trials. And so I'm not sure if Daniel has any other follow-up questions on that, but I hope I've answered his question. As far as developing a ring that has multiple drugs in it, we, as I mentioned earlier, we have supported, or in the chat I mentioned, we have supported an actual ring in phase 2 clinical trials along with CDC to investigate the pharmacokinetics and safety of a dual purpose ring, the tenofovir LNG ring to protect against HIV and potentially HSV, as well as unintended pregnancy. So the possibility of having a ring with multiple drugs in it, even multiple HIV drug classes incorporated into that ring is definitely a possibility. And I think for the third question about oral PrEP and PrEP ring, I believe as part of the implementation science studies that I mentioned briefly, those women will be offered both, and it'll be interesting to see what women tend to choose as part of those studies. So that work is being planned, and those studies are just now ramping up or close to ramping up. Thank you.
Great, thank you, Shannon. I'm not sure if we lost Daniel or if he's just not feeling like taking himself off mute, but if he has any follow-up questions, hopefully he will pop those into the chat. Daniel did ask actually a question, a follow-up for Valerian, and he's saying, talking about TFU eligibility, any proposed criteria that can be applied at the time of circumcisions? Valerian, would you mind answering that one?
Yeah, sure. Thanks very much, Daniel. That's a great question. Apparently, given that I'm not so much on the ground these days, I was hoping that the programs can continue screening clients the way they were doing, but instead of letting them through to receive circumcision, they make decisions to instead link them to care and treatment services. Some of these services are directly located within the facility. Others may be at different locations. So recently, we've been encouraging programs to not just refer clients, but link them to facilities, making sure that clients don't queue up behind other clients, but since they have been already at the facility, they can go straight and receive services at the facilities where they have been referred. So I was hoping that programs can actually continue doing the same, but instead they shouldn't be providing VMMC services immediately somebody is HIV positive without checking with if these clients have already been started on ART. So I hope that programs can develop some guidelines around HIV positive men that can be followed at most of the facilities, such that clients can be picked out and these guidelines can be followed. For example, test through appropriate HIV testing and counseling services, and then counsel these clients once they turn positive about the next steps, and then they have to be they work with one of the providers or the community mobilizers. Usually they have been helping in this area to link and probably escort clients without stigmatizing these clients to other facilities, and then clients can be enrolled, and then clients can be given information on how to return for VMMC services, which should be available. I also need to mention that this was a decision we reached. We think it was a hard decision because we understand the implications of picking out HIV positive clients. They have their reasons the programs were allowed to continue circumcising these clients. VMMC per se doesn't benefit them so much like it benefits the HIV negative, because they cannot, it doesn't prevent HIV transmission to their partners. And then we've also noticed a lot of severe adverse events. So what they benefit mostly from right now, once they come at the facilities and test positive, is to be on ART. So we want to do the best for them, and we need to find the best ways to do it without causing any form of stigma. Over.
Great, thank you, Valerian. That was good answer. Daniel has very curious, has lots of questions. But now we have one from Simon Sikwezi in the chat. I'm not sure, Simon, if you'd like to come on and ask, but I think your question will probably be music to Jacqueline's ears.
Yeah, I can come in and just maybe elaborate.
Yes, please.
Go ahead.
Yeah, thank you. Just briefly, yeah, I was actually very excited with that presentation and the case studies that you provided for partner organizations that have implemented SP interventions and looking at the impact they've had. So my really concern is the issue that you did highlight, that there isn't like a specific guidance in the COP regarding SBC, but also we don't have SPC specific budgets. In our organization, I work with Pakacheri in Malawi. We're implementing LEAP, which is local endeavors for HIV and AIDS prevention. We're working with female sex workers. I think we do have a lot of SBC gaps in order to understand, for example, when we enroll girls in PrEP, some drop out. There's so many reasons, and we'd like to really understand why they're dropping out and what is it that we need to do to make sure that we bring them back to PrEP and then they adhere to PrEP. So too with ART, there's a lot of treatment interruption for ART. We would like to understand why is it that they are dropping out of treatment. We should understand from the different typologies, for example, female sex workers, and all these require that we have at least some resources that will enable us follow the human-centered approach, collect information regarding reasons why, what are the barriers, what are the issues, and then how can we design interventions that will enable them be returned to treatment. So my question really was, isn't there a way that maybe USAID PEPFAR could look at providing not a huge budget, but something that we can use to collect the insight, because some of the skills and experiences we have them within the offices, but we need to be supported in terms of collecting data. Then we can do the analysis and come up with a design SBC interventions that will improve achievement of program outcomes. So really the issue is, how can we do this, and how can USAID consider including a certain, at least a provision for SBC budget? Thank you, and over.
Simon, Catherine said it well. Music to my ears. I, as an SBC advisor working in this field for, I won't even tell you, probably longer than some people have been around, but I totally share your frustration, and I need to be politically correct, right? This is all being recorded. I know that in the PEPFAR listening sessions, there were a lot of, outreach from SGAC to get concerns, and behavioral science, behavior, whatever you want to call it, was frequently mentioned. Will there be some kind of shift in the next kind of strategy, PEPFAR strategy, to reflect that better? Will administrator power be able to influence SGAC? A lot of questions. I totally understand you, Simon. I wish I could say, yes, we have a solution. We don't, but not in the short term. But what I want to encourage you to do is really leverage what's out there. There's sometimes, you know, some of the studies, for example, MenStar on, you know, this is not a KP example, but the same kind of insights are coming up again and again. It's not that there's not the importance of having local data. Of course, that's always the best, but kind of go down, what's second best? What other information can I use? What is an environment that is similar enough that I could adapt the approach? Can I, for example, test, and maybe it's reframing as implementation science so that you iterate, and maybe it's through an M&E process that you get sort of that learning and that sort of iterative information that you would get from traditional formative research. I don't have a solution, Simon. I would say when COP guidance comes out, there's an opportunity for public comment away. Let's use different sort of inputs to influence. And I hope I haven't strayed too much on the political incorrectness for this response. But thank you, Simon. I share your concern. Over.
Great, thank you, Jacqueline, for your forthright answer and being clear. I'm not seeing too many other questions coming through in the chat, but I want to make sure we do have about 15 more minutes left in this session, so there is time to type away your questions again, or just raise your hand. But I do have Daniel. Our questioner just had a clarifying point for his last question on VMMC. He was actually asking, and this is, I think, probably just my ignorance as a moderator, when he said TFU, I didn't know myself that was telephonic follow-up. So he was wondering if there is any eligibility criteria envisioned for VMMC clients for telephonic follow-up. So again, that's my mistake. So Valerian, are you able to clarify about eligibility criteria and telephonic follow-up?
Oh, apologies. I mistook it for the other new change. Yeah, well, for telephonic follow-up, the criteria is, I think many programs have already been doing this. When we suffered the COVID-19, we decided that it was okay for programs to report follow-ups using telephone and then capture notes into the client CRFs. So one of the things I still think also there are going to be criteria developed, like a kind of protocol on how to proceed with this for programs. But I think from my perspective, I think we need to evaluate if a client has a phone in the first place before we say we shall follow you up with your phone, or if the client has access to a phone through a friend or their wife or one of the mobilizers who can actually reach to this client, and then telephonic conversation can be conducted. Once we establish that there is access to a phone, then we can give this client instructions before they leave that we shall follow you up on the respective days, day 2, day 7, and if possible, day 14 of follow-up. And for shingling, day 7 is very important, and then other follow-ups. So if the client doesn't have access to a phone, then we need to make sure that this client can be seen back at the facility for follow-up. And then if a client has adverse events, moderate and severe mostly, according to any conversations on the phone, we can encourage them to come back to the facility, or we can have somebody go to their home to check on their status. So the phone should be used specifically for clients that have no challenges. And once we identify challenges, whether through our telephonic conversations or through a client reaching out through either a mobilizer or through other means, these clients need to come back to the facility to be helped. So briefly, those are things that I think need to be included in the criteria for telephonic follow-up. I believe there could be additional points added onto that once we develop this, but it would be very, very important to ensure phone access for each of the clients we think want to follow up telephonically. So I think that's what I can say briefly. I also want to encourage everyone that once the COP guidance is out on the 8th, feel free to put your comments into COP guidance. They will receive responses back from the COP guidance drafters, such that you can receive some of those responses directly through that approach as well. Thank you. Over.
Great, thank you, Valerian. Daniel, I hope that clarified and answered your question in the chat. I want to give everybody else the opportunity. I mean, I can see that this is a pretty well-attended session. We have more than 60 participants here today. And we have, our USAID experts here to help answer any of those burning questions that you have about COP guidance or about, implementation in terms of, all of our prevention activities, SBC. So I'm not seeing any other points in the chat, but I do want to make sure that you have full access to ask our experts today. So I'll be quiet for just a moment, and please feel free to take yourself off mute and come on and ask any of your questions. Well, this must have been one of the clearest presentations ever. So thank you very much for coming, for your questions. I think we'll stay here for just a few more minutes, just in case there are questions that come through in the chat or in case anyone else would like to answer. I hear somebody. Go ahead.
Yeah, I'm Tikazi Jere from Zambia. And I wanted to find out on these prep activities, like the last speaker, he says they were using phones, but is there an intervention where people use physical visits? Because I'm working in the rural parts of Zambia, in northern Muchinga and Luapula provinces, and the phone is more like a luxury, and sometimes it's not easy to get these clients. And I know that our prep retention is poor. So I don't know if anyone has got other strategies other than using digital equipment to get to patients. Thank you. Clients.
Hi there, I can try to offer some guidance. This is Allison from the prep team. That's a really great point. We have seen during COVID that a lot of the adaptations have been towards moving to virtual platforms, to telehealth services, to for demand creation, for prep initiation support and prep continuation support. But noted that it can be difficult in areas where access to those services is limited. So a few thoughts that crossed my mind. We have seen adaptations in which it's virtual platforms, but it's not telehealth visits. So, and by that I mean it's WhatsApp support groups, it's peer educators following up on WhatsApp or through SMS. So that requires a little bit lower bandwidth than a video visit. Other things are, working with people in the community, identifying people in the community that can provide that, socially distanced, properly protected, but in-person support to prep clients or for demand creation purposes. There have been support, smaller support groups so that it's safer during these times in order to reach people. But the other point is really working towards overcoming that over-medicalization of PrEP. So how can we move PrEP services out into the community as much as possible in order to reach people and to lower those barriers? So there's been a number of adaptations. I'm thinking specifically of our Dreams program, which has, again, moved towards smaller socially distanced groups, more localized. So potentially having, an assigned PrEP champion or PrEP peer educator in a more local community in order to reach those more rural or kind of further away from facility clients. So those are just a couple ideas, but I'll also plug that our PrEP team recently did a COVID adaptation survey, and we'll be sharing out the results of that survey that can provide more insight into adaptations that could address these challenges.
Great, thank you, Allison, for that answer. And I also encourage any of the local partners who are on the call today, if you have had any adaptations that are non-telephonic based, if you've kind of had any ideas in your programming, you're also welcome to share here about ideas of ways that you've adapted to rural situations. And so we'll definitely, please raise your hand if you have an idea for our colleagues. But I do see Xavier Biggs, you have raised your hand. And so I want to call on you and be sure to give you the time to answer or ask your questions.
Thank you so much.
Thanks a lot for that, Alison. Oh, sorry, Xavier. All right.
Morning or afternoon, or I have a question that might have, I'm not so sure if any variant of it has been answered before because I had to move away at a point. And it's not so straight line fitting into the virtual adaptations, but have you had any situations where before PrEP was available in Jamaica, we had tons of people asking and were very, very excited about its introduction to this space. And then when it became available, the uptake was less than optimal because now people expect that other people will take it so that they can benefit from the protections. Have you had that particular unique experience, and how have you overcome that as a hurdle?
Wow, that's a very unique question. And I do hope our panelists are able to answer. Thank you, Xavier, for bringing in your perspective from Jamaica. That's an interesting question. I think probably also one for our social and behavior change folks in terms of perceptions.
Yeah, maybe I can get us started, and thank you, Xavier. It's great to have you on the call today. I know the Jamaica PrEP program is just kicking off, so great to have you on. And maybe before I even get into the answer, I will plug the PrEP panel happening tomorrow that features 3 local partners sharing their experiences. So I can't think of that specific situation, but I will say that in other countries there has been concern, anxiety. We've seen it in countries where PrEP implementation is just starting around, okay, if we introduce PrEP into this context, are other people going to stop or decrease use of other HIV prevention interventions such as condoms? And so, and therefore, is it actually going to make more risk for STIs or even HIV if there's this assumption that, other people are protecting themselves? What I can say is that the data shows that that doesn't happen. So there isn't increased STI risk after PrEP is introduced. There may be an increase in STI reporting because PrEP visits do include STI testing, as there's an increase in STI testing. But PrEP not only introduces the HIV prevention option, but also provides opportunities for clients to talk with healthcare providers about their overall sexual and reproductive health. So data shows that this fear that it will increase risk in the community isn't real. It's a perception. And maybe I'll stop and see if Jacqueline would like to say anything about SBC.
Hey, thanks, Allison. You're the PrEP expert. So yeah, no, I think definitely debunking any kind of misperception is definitely important. So Allison just really hit it. The other thing to consider is, Allison, you talked about, demedicalizing. I think part of it in how we communicate around PrEP, just SBC perspective is, I mean, once you get over what the HIV protection, the more rational benefits is, how are you framing the benefit for that particular audience? And sometimes the insights tell us it's about gaining control, about independence. So I think part of the demedicalization is also how to frame it in drivers that resonate for the audience, right? And it's kind of like if you want somebody to lose weight, are you going to stress cholesterol or kind of biological markers, or are you going to talking about feeling good, fitting in your clothes, etc.? So I think it's really about getting the insights, but it's not answering your question, Xavier, but I'm going to throw that in terms of the demedicalizing as part of the demedicalizing approach. Over.
I think in a way it does, actually, because I think a lot of the let me call it hesitancy, in the absence of a better word, comes from that over medicalizing of the concept. And so maybe there is a response in that. Thank you.
Yeah, I think that's a great point, Jacqueline. Thank you so much for your thoughts. And that's why at the end of my presentation, we talked about normalizing PrEP. So normalizing what PrEP is, how people use it, creating across the community. So PrEP isn't just for a certain population. PrEP isn't because of this or that. PrEP is, as Jacqueline said, something that people can use to empower themselves as a self-care, to take care of their own health, take control of their own health. So we've learned lessons from the couple of years of PrEP implementation so far, and I think that that's one huge lesson, is normalizing PrEP and moving it away from PrEP is for a specific person or population.
Great, thank you, Xavier, for your question and follow-up, and Allison and Jacqueline for your responses. I just want to plug that we shortly after this we have a quick break for everybody that is on our local partner panel. So we have 3 sessions beginning at 9:45. So it is now it's just a little bit before 9:30 here Eastern Standard Time. And we have a panel on staffing and staff retention for local partners, social and behavior change, and dreams. So those 3 panel sessions will be starting at 9:45 Eastern Standard Time, 3:45 Central African Time. So definitely encourage you to go to those sessions, but go ahead and take a break, have a breather, have a snack, and then come back for those sessions. And then I also wanted to just let you know, we're excited that Administrator Power will be joining us today at 11:10 Eastern Standard. I believe that's 5:10 in Central Africa time. And she's going to be taking questions from a few of our local partner prime organizations. So we're really excited to have just a brief few moments of her time. And I hope that you'll be able to join us for that session in a little while. So I hope you all are having a great day, and we will see you in the next session. Thanks, everybody.
Bye now.
Thank you.